accustomed to how these quizzes are going to be with meds, right? This is technically the first actual mental health quiz. Very dominant meds. So you'll expect that for next week. Major depressive disorder, the proctor loves it. Okay, the proctor loves this topic. Okay. Okay, thought I'd include this because Office fans, don't you guys think these two had depression, specifically Toby? Guys? I mean, Michael Scott didn't help. He totally gave Toby depression. And Michael Scott himself, we're gonna learn today that I definitely had MDD, right? Yeah. Big time. Big time. Actually, everyone in the office had some form of psych issue. Okay. Okay, let's start with MDD so we understand what the heck this is all about. Okay? So, major depressive disorder. Major depressive disorder. A bunch of shit going on here. Sorry, guys. Persistently depressed mood lasting a minimum of 2 weeks daily. Okay? That's how you're considered. He has all the negative symptoms. He does. A bunch of MDD symptoms are negative symptoms of schizo. Okay? Okay. So, in order for you to be considered that you possibly have depressive-like symptoms, persistently depressed mood lasting a minimum of 2 weeks every single day. Now, from these symptoms, you need to have at least 5 or more symptoms daily for 2 weeks. So, anhedonia, I would bold that one. Insomnia, which is a typical symptom, okay? Typical symptom. So, insomnia, cannot sleep, or too much sleep. Since they don't sleep all night, then during the daytime, hypersomnia, changes in appetite, indecisiveness, weight gain, weight loss. Okay, so 5 or more in order for the psychiatrist to be like, you know what, let's monitor you some more. Now, the most important symptom here is what? SI, suicidal ideation. That should be the first thing you think about when you think of a patient who has major depressive disorder. That's the first thing you're going to assess. Okay, priority. So, anergia is one of them too, lack of energy. Anhedonia, lack of pleasure. There's a reason why I'm pointing out these symptoms. You're gonna see them, okay? So, 5 or more. Anhedonia, insomnia, which is typical. I mentioned it. Difficulty concentrating, indecisiveness, weight gain or weight loss. Obviously, SI is number 1. Does that make sense, you guys? This is the umbrella, major depressive disorder. Under major depressive disorder, we're going to go over other depressive disorders, right? So this is the umbrella one. This is the major one. Okay, make sense, guys? All with me? Thank you, guys. Okay, more in depth. So I'm on the unit. I'm caring for my patient who was brought in because he verbalized SI, suicidal ideation. He was, danger to self, so he's possibly on a hold. Yes, 5150 in our scenario. And when I'm assessing him, these are the symptoms that I'm going to possibly see. Okay, again, we went over this, right? Lack of energy, anhedonia, anxiety, irritability. Oftentimes, when you assess them, you're going to see them walking down the hall. And if they're agitated, they're just not going to be able to sit still. Sluggish is very common. Or if you're going to walk towards them and they're going to refuse to move to the side, you're the one who's going to have to move to the side. Changes in eating patterns. So at this point, we understand that psych diagnoses are not standalone, right? There's always another psych diagnosis accompanying them. So anorexia and MDD. So a lot of patients who do have major depressive disorder, they don't eat, so this leads to anorexia. This can lead to, or if you have anorexia, it can lead to a form of depression, okay? They go hand in hand. When we talk about anorexia, I'll tell you about my experience before I was in recovery and how that connected to it. And constipation is a common finding for MDD. Sleep disturbances, remember the typical insomnia symptom, decreased libido, and lots of somatic reports. Somatic reports such as what? Right? Having abdominal pain, although there is no underlying issue, right? GI changes, although there is no underlying issue. Having pain anywhere, although there is no underlying issue, very common finding, okay? More. Look at all of this. I got a notification saying you cannot see my screen. Can you see my screen?
We can.
Oh, you can. Okay, thank you. Why did I get that? And look at all of this, the A's. Remember the 5 schizophrenia A's? Obviously, this isn't schizophrenia, but same. These are the main symptoms. Sad with blunted affect. No emotion, completely. Poor grooming, lack of energy. We're going to talk about how you're going to have to promote independence and autonomy and actually prompt them to go take a shower, to go take care of themselves. Psychomotor retardation versus agitation. So it could be either one of them. You can either be very, slumped, sluggish, or you could be restless and pacing and kind of agitated. Socially isolated is very common. We're going to talk about placing them on one-to-one, slowed speech, delayed response. The other day, I was doing group report with my patients, group therapy, and I had 5 patients. One of them had major depressive disorder, and it was his turn to share. And I asked him, "What is your goal for the day?" And he looked at me, and he didn't respond for a while. And one of our patients, who was currently in the manic phase of his bipolar disorder, started to just act out and say, "Come on, man, respond, blah, blah, blah." And I said, "No, it's not your turn to speak." So it's not because your patient doesn't understand what you're asking them. I promise you, this is a test question. It's because it takes them a moment to kind of process what you're trying to say. So if you're asking your patient a question, give them time to respond. Oftentimes they'll just look at you and sigh, and then they'll respond like 1 word, 2 words, a phrase here and there. Okay? Does that make sense, you guys? Okay, I think this is a brilliant way to remember the signs and symptoms of depression. Sick caps. Okay? Use this as a mnemonic to kind of guide you with the signs and symptoms when you're responding to these questions. Sleep disturbances, interest loss, guilty feeling, energy changes, concentration, appetite, psychomotor changes, suicide. Suicide, I would put first, and then sleep disturbance, I would put last. Does that make sense? But this is the way to remember. I promise you, when you're taking that proctored and you want to remember the signs and symptoms, use this. And for my exam too, obviously. Right? Really good way. Really good mnemonic. Okay, I thought I'd include it in there just for your sake, you guys. Are you guys with me? Are you guys all drained? Kind of tired? I know. I know. It's okay. You can do that. We got this. I'm just checking you guys out now. All cameras should be on. For points. Let's talk about risk factors. Okay, so we talked about diathesis stress model so many times already, but let's nature versus nurture has a lot to do with it. We have genetics that come into play, vulnerability, environmental vulnerability, a possible stressor. But let's see. Family history and a previous personal history of depression are the most significant risk factors. Absolutely. Genetics increases your chances, like triples it. Okay, twice as common in females between ages 15 and 40. Why? What do you guys think? What happens between ages 15 and 40 for females? What happens to us, guys? Puberty, hormones, pregnancy, We have babies. We're going to talk about postpartum. We'll briefly touch on it, right? All this stuff happens to us, to females during this time, kind of unstable hormonal changes, right? Now, it's also very common in clients over 65, but it is more difficult to recognize in an older adult client. Why? Because above 65, we automatically assume, if they're agitated, if they have memory loss or behavioral problems, we think, well, dementia, it's part of aging. However, it's oftentimes misdiagnosed. Clinical findings of depression that look like dementia, memory loss, confusion, and behavioral problems. When I was visiting my home care patient like 3 days ago, I called him up and I said, "Hey, I'm going to visit you. It's your nurse. I visited you last week." And he's like, "Who is this? Who are you? I don't care. Don't come here. I don't need you." Okay, so agitated and isolated, lives on his own, is irritable, memory loss, kind of confused sometimes. But the deal is, there is no diagnosis of dementia. The doctor refuses to diagnose him because he doesn't fall under that criteria. He's actually diagnosed with depression now. He actually has that. So we got to be a little more considerate when we come across our grandparents or those who are elder, right? A lot of times their anger has nothing to do with them just being angry. It's because they're possibly depressed, right? Are you guys with me? Stressful life events, like West Coast University is a stressful life event. How would you define the dementia? So with dementia, um, psychiatrists have a certain like diagnostic criteria. Dementia is not sudden, right? It's progressive. So if they're progressively seeing the symptoms, then they can lead towards dementia. But with these symptoms, the memory loss, like sudden delirious type memory loss, confusion, it's kind of like, you have to look at, possible behavioral. So for dementia, if they wander off, above 65, if they wander off, and there are gaps in their stories. These are diagnostic criteria. Gaps in their stories. What was the doctor telling me? Wandering off, gaps in their stories, persistent falls. Um, they consider all of that. With depression, I remember talking about this with a psychiatrist. It's are they isolated? Are they angry when they actually talk to someone, or are they angry in general? All of that. It's like diagnostic criteria that doesn't really pertain to nurses. You know what I mean? Um, very very similar, but there are certain like distinctions that the doctors look at. Does that make sense? Maybe it doesn't answer your question, but it's very specific to how doctors diagnose using that DSM-5. Yeah. Stressful life events, medical illness, women's excuse me, postpartum. I'm pretty sure mental health is a stressful life event that we're currently going through. Substance abuse, all right? Drug abuse. We're not going to touch on drug abuse right now, but when we do cover it, um, when we do cover it, there are certain drugs when you come off of. Depression is one of the symptoms, okay? Being unmarried, I guess that's very cultural, right? The amount of times my family asks me why I'm not married kind of leads me into like a depressive state because they keep asking me, right? Trauma occurring early in life, death in the family, death of a loved one, okay? Whatever, it doesn't even have to be death. It could be PTSD from a possible abuse, right? Possible physical abuse, sexual abuse. Absolutely. That's any form of trauma, okay? Are we good, you guys? Do we understand the risk factors? Cool. I'm not gonna, you know, go in detail on this, but it's very like I don't work with kids, but this touches on children and adolescents. Leading cause of disability in the U.S. How about that? Isn't that very upsetting? Children and adolescents, children tend to be more irritable than depressed at times, affecting children at 8%, 6.7 young adults. Okay, so I don't work with children, but the one time that I did with students on the psych unit with kids, so there was this one 8-year-old patient who was very irritable, restless, didn't follow rules. I mean, she was slowly but surely escalating. She would touch all the other kids on the unit. She would find rubber bands, I don't know where. They're not allowed to have that, and she would flick it on my students. So we approached this 8-year-old girl, and I was telling her, please don't flick these rubber bands on my students. And I said, where did you find this? You can't have it. I'm taking it from you. And she said, it's mine. I brought it with me and I put it up there. Are you guys following? I had it up there when I came. I was like, okay. You know, I obviously got my glove. I got the rubber band. So it was kind of traumatizing, and I really wanted to know the entire backstory. Remember, she was irritable. She was behaving very provocatively. When we looked at her chart, so this 8-year-old girl was trafficked by her father, raped, sold out at 8 years old. To understand all of that, and her diagnosis was depression. At that age, I mean, I was heartbroken. I was heartbroken. That's when I started to correlate irritability with depression in children. Okay, I couldn't. I would cry big time. I did. We were traumatized that day. This cute little 8-year-old girl. I couldn't. I can't work with kids too. I don't work with kids. I love kids way too much. Okay, I don't touch on this. All I need you guys to know is the diathesis stress model, nature versus nurture. Cognitive theory may acquire depression due to early stressful experiences. Well, this is where cognitive behavioral therapy comes in after your patient is discharged, after you stabilize them, which we will talk about. You don't just discharge them home. Therapy is utilized. You know, after you're stabilized, you're on all these meds. Well, let's find that thought in your head that makes you feel this way and think this way, and let's alter it. Okay, let's develop those coping mechanisms. Okay, not that I would include this, it's also in your book, but check this out. I'm pretty sure maybe not all of you guys are going to be psych nurses, but you guys are going to administer a bunch of these meds, right? You guys are probably going to administer lots of statins, right? For HLP, right? Elevated triglycerides. It's actually statistically known to cause depression, even if you don't have any history of it. So we have all these issues, right? Like we have all these diseases and we have meds for them. And so these meds cause other problems, and then we're going to treat those problems with more meds, so on and so forth. This like medication world is not really the greatest one. But I thought it was interesting. Corticosteroids linked to depression. Isn't this, I don't know, I find this to be very, come on, nurses, we need to know the meds, right? Why are we administering all these meds? Just thought, you know, to correlate it. Now, let's move on to the biochemical part before we move on to the major signs and symptoms. So, dopamine with schizo, the major biochemical, okay, is serotonin and norepinephrine, okay? Get this. I'm sad. Two of the main neurotransmitters involved, serotonin and norepinephrine, are meds that we're going to talk about target these two hormones, okay? They try to stabilize them in order to get that valid baseline, okay? Serotonin deficiency, mood, sexual behavior, sleep cycles, hunger, pain, perception. Norepinephrine is your attention and your behavior, okay? So our meds are targeted towards that specifically, okay? Are you guys with me? Alert oriented times 4? Times 4. Perfect. Okay, so let's talk about persistent depressive disorder this time. Your proctor loves this, by the way. Just saying, because a little birdie told me that. Okay, so This is actually very common in kids and teens. Okay, so chronically depressed mood that lasts more than 2 years, less severe than MDD, milder form. Okay, so with MDD, you needed what, 5 symptoms? With this, you need at least 3 to be considered, you know, hey, you've got dysthymia. Okay, insomnia can be one of them, lack of energy, okay, weight changes. So persistent feeling of depression for 2 years, less severe than MDD. Early onset childhood and adolescent, okay, lasts at least 2 years for adults. Know this. 1 year in children. If this isn't treated, this can lead to major depressive disorder. Okay, so when I was, going through my anorexia phase, pretty sure I had dysthymia. I didn't realize this until I was at West Coast University studying dysthymia in Tan's class. I was like, what? Am I reading about myself? This is it. So it's so important. If these are symptoms that you notice, you gotta get treated right away before it leads down a darker path. In agreement, right, guys? So 3 more symptoms. Okay, 3 clinical findings of depression. Okay? Okay, premenstrual dysphoric disorder. PMDD. Serious stuff though, guys. Severe depression and irritability in the week or 2 before menstruation. Okay, emotional, persistent or severe anger, lack of energy, overeating, difficulty concentrating. So rapid mood swings, lack of energy. Okay, so I used to be a floater in the ER. I would float to the ER constantly. And we had a patient come in one night, this male. He broke it, his arm was broken, okay? And when we asked him what happened, he said his girlfriend was talking about how she's on her period and she feels horrible. And apparently he didn't take it seriously, so she pushed him down the stairs. And she was right. The cops brought her in too, handcuffed. She was later placed on a 5150. No reactions to this story. A lot of us on the unit, we were having, even the patient was laughing. Okay, even the patient was laughing. I think there's serious severity to PMDD. Okay, I like it how no one gave me reactions to this. It was his fault. Were they still together? No, they were not. She was placed on a psychiatric hold. He was laughing. I think he should have taken her obviously serious, right? But pushing someone down the stairs, extreme behavioral changes, danger to others. But he never imagined it. They don't know the pain though. Yeah, they don't. But after working in psych for a very long time, you kind of start to distinguish between extreme measures and non-extreme measures, right? Yeah. Both of them had some serious issues going on. Seasonal affective disorder. Sad. Depression during winter months associated with less sunlight. With this one, this is where seasonal affective disorder occurs in states or in cities where you live with less sunlight, like Seattle, Alaska, okay? And we don't even use meds for this. Washington. First line is light therapy. First line of treatment is light therapy. That's all we use. That's all we use. We don't even go for meds. It works. Light therapy works. That's why in these cities or in these states, they actually have places where you can go to, and they have like a beach-like induced environment. I don't know what it's called. Where you go, like it's like raining outside and thunderstorm, and you go to this place, and it's like it's like a simulation of the beach. Okay, that it works. Or you just do light therapy. Okay, substance-induced disorder. I'm not going to talk about it so much because we're going to talk about it in substance abuse. But use of withdrawal from certain drugs that you withdraw from, such as meds, certain opiates, possible benzos, and some other hallucinogens. Depression is one of the withdrawal symptoms. We're not going to target that. We're not going to talk about it right now. Okay? Now, your patient who has depression comes in, right? How the heck are you going to screen them? What's the first thing you're going to do? The first thing you're going to do, and we'll talk about it more, is ask them, do you have a plan to kill yourself? You're not going to trigger them by using that word. Do you have a plan to harm them, to harm yourself? Okay, this is priority question. Priority. Okay, now, there are so many screening tools here. Okay, Columbia Suicide Rating Scale is the one I'm going to utilize. Okay, Hamilton Depression Scale, Geriatric, Exam, Patient Health Questionnaire. They're all very popular. However, West Coast covers this one. Okay. Let's go over it. So, guys, for my exam, okay, so the way you're going to study for this is it's going to be very self-explanatory in the exam. Our patient comes in with depression. We ask all of this. So, do you wish to be dead? Have you wished you were dead or wished you could go to sleep and not wake up? Right? It doesn't have to be verbatim this way, but we ask them, okay? Suicidal thoughts. The main one. Have you actually had any thoughts of killing yourself? So, if yes to this question, to number 2, it's even all right here. You ask them 3, 4, 5, 6. If they say no to 2, you go straight to 6. Okay? So when you're studying for this, know the questions, the underlying questions, and understand when you go to number 6 and when you just have to ask all of them. Am I making sense, guys? Okay, perfect. I don't want to stay focused on this because it's very self-explanatory, but this is how you should be studying for this, okay? So priority question, someone comes in for MDD or, they're on a hold because they had maybe a suicide attempt. Do you have thoughts of killing yourself? Okay, that's the first thing you're going to ask them. Okay, risk for suicide. Okay, that's the priority nursing diagnosis for major depressive disorder. Now, I know that West Coast no longer utilizes NANDA, and I think it's just like the BRN is the new thing. But risk for suicide, safety highest, always highest priority. I'm going to utilize that. Okay, that's something that you guys need to know. Okay. Now, there are 3 phases of care. I don't dive too much into this, but briefly, acute, continuation, and maintenance phase. 3 phases. Okay. Now, acute phase lasts 6 to 12. In this phase, your patient is possibly hospitalized. They're experiencing all the depressive symptoms we went over, either 5 or more or 3 or more, depending what type of depression they have. Okay? And in this stage, they're on a 1-to-1 because safety first. You do not leave a patient alone if they are verbalizing SI. Are you guys with me? 1-to-1. And then continuation phase, 4 to 9, increased ability to function. At this point, the meds have kicked in. They're complying with their meds in this perfect scenario. Okay, meds have kicked in. Increased ability to function. Your goal is to prevent relapse, which means make sure your patient is taking their meds. Educate them on coping skills so they can know how to deal should a stressor come along their way again. Acute phase. This is the continuation phase. The increased ability to function is the continuation phase. And then maintenance phase, remission. At least over a year. This maintenance phase is at least over a year. Your goal is to prevent future depressive episodes. At this point, your patient is discharged, and they're not just discharged home, right? Possibly an outpatient type situation where they can work on cognitive behavioral therapy, right? That's what they have to focus on. Okay, nursing care. I know I verbalized this, but I'll say it again because it's important. So first thing, okay, do you have thoughts of harming yourself? Direct. Assess for thoughts, risk factors of self-harm, and suicide in all patients with depression. They're going to say yes in our scenario. You're going to implement a one-to-one for patients at risk for suicide and who verbalize SI. You don't even need a doctor's order for a one-to-one. You can place them without getting the order, then you can tell them later. It's part of our scope of practice because it's your observational critical thinking skills. Your patient should not be in a private room. Place them in a room close to the nurse's station with a stable roommate. Okay, this is no time for privacy. You need to watch them at all times. Okay, closely monitor patient during med admin due to risk for discarding meds and saving to overdose. We're going to talk a little further about this when we speak about suicide, but when you're on that one-to-one, okay, never close the door ever in your life. Door open always. One-to-one, close within arm's length should anything happen. Make sure you can see their hands when you're giving them meds because they can easily spit them out and kind of cup them, kind of in their fists. If their fists are clenched, ask them to unclench and see, do you have any meds? Because a lot of times they do. Okay, it's better to be safe than sorry after your patient ODs, right? That's not something that we want. So closely monitor the patient during med admin. Okay, I'm that nurse who has the pen light and actually says, okay, especially if they have history of hoarding meds, I'll ask them to open their mouth. I'm going to check under the tongue, cheeks. A lot of the times they kind of hoard them in between their teeth. They're very clever, okay? And of course, encourage independence. Remember they're sluggish. Remember they fail to groom and hygiene, right? Lack of it, right? ADLs, encourage independence. Did you brush your hair today? Did you shower today? Hey, let's take a walk. Okay. Would you like your makeup? Do you want to put, encourage them. Remember, this is something you can delegate to the UAP. Okay. Am I making sense, guys? Okay. Now, communication. I kind of went over this a little bit. Okay. Make time to be with the client even if she does not speak. It doesn't matter if you're in group therapy and they're not speaking, just take that time to be with them. Okay, it's okay, even if they're not responding. Okay, give directions in simple, concrete sentences. No one cares about a list. No one cares about a novel. No one cares about how beautifully you can articulate yourself. Short, simple, to the point. Remember, too much is hard to comprehend for someone who already has a decreased attention span. Short, to the point, and give them time to respond. Do not rush them. Do not rush when you want them to answer to your question. Okay? Very, very important. Okay? Now, that was depression, signs and symptoms, how to care for her. We're going to dive into meds right now. Let's respond to this together. Which question would be priority when assessing for symptoms of major depression? We know this. Tell me about any special powers. You look really sad. Have you thought of harming yourself? Your family says you never stop. P. P. Does that mean you guys are going to ace next week's quiz? Okay. Are you guys good? I want to make sure y'all are good. Checking you guys out. Some sad faces, some happy faces, some cameras off. I know who you are. Okay. We're going to talk about meds. A bunch of meds. We're going to talk about SSRIs, tricyclic antidepressants, MAOIs, atypical antidepressants, SNRIs. So our meds are going to be in that category. Okay? Oops. Okay. Our meds are going to be in that category. So with schizo, we discuss positive, negative symptoms. So if our patient had only negative symptoms, or only positive symptoms, we would go for the what? For the first gen, right? And then if not, then we would go towards, if they had both, we would go for the second gen, right? With this, there is no superiority over which antidepressant the patient is going to use. Okay? There is no superior. The doctor's not gonna, right? They don't do that. It depends on how well the med works for each patient. It's very individual. All treatments, switching occurs when there are intolerable side effects. Again, I can be started on a med, it might not work for me, or I have horrible side effects, and then I move forward. The doctor will probably start me on something else. So a lot of the times, by the time I reach a med that works for me, it's going to take a long time. So there's no clear guidelines on how to choose, okay? Okay, let's talk about SSRIs. Okay, so you guys know I posted the metrics also. These are very popular SSRIs. Bold, the ones that I'm telling you, not all of them, but obviously Celexa, Lexapro, Prozac. For my class, I don't care about dosages. It doesn't matter to me. Prozac, okay, Paxil, Zoloft, all of that. Now let's dive into the most important ones. Okay, so SSRI, selective serotonin reuptake inhibitor. Okay, increases your serotonin because you lack it. Okay, now Paxil and Zoloft, leading treatment for depression. Now I know there is no top priority, but according to theory, these meds have been chosen. These meds have been seen to have to work better and to possibly have less side effects. But the most common ones: Celexa, Prozac, Paxil, Zoloft, leading treatment for depression. Now, adverse effects. Okay, what I would focus on: agitation, insomnia, anxiety, like CNS stimulation, nervousness, weight gain, sexual dysfunction, right? Cognitive would be word finding. So these are, it automatically goes to adverse effects: nausea, vomiting, nervousness, headache. But this is what I really care about when it comes to SSRIs, because it's if there is ever an adverse effect, it'll automatically lead to serotonin syndrome. So there's never a time where your patient is on one SSRI. Oftentimes they're on 2, 3. So that means it's too much serotonin. So I'm going to watch out for serotonin syndrome. Okay, it's even bolded. If signs and symptoms of serotonin syndrome are present, stop the med and notify MD. Okay, agitation and insomnia are one of the first symptoms that pop up when it comes to serotonin syndrome. And then fever and diaphoresis follow. Okay, so I would watch out for that. Okay, now, so we're on all these meds, on all these SSRIs, one too many. We have serotonin syndrome because of that. Now, a lot of the times our patients also are on herbal supplements, and I'll touch on it later on too, but you cannot take St. John's wort, which is not regulated by the FDA, right? Most herbal supplements aren't, but you can't take St. John's wort with any SSRI because it increases your serotonin syndrome. If you do, your heart will just beat the fastest, tachycardia, your blood pressure will be up and down all over the place. Not even just up or down, it'll be all over the place. Hyperflexia and incoordination, okay? Those are the main symptoms, specifically labile, BP, and tachycardia, okay? Are you guys with me? Did this make sense? So, SSRIs target serotonin syndrome. Too much equals serotonin syndrome, right? Too much. So, and no St. John's wort. Okay? That's not, we can't do that. Okay? Oftentimes it becomes a code. Serotonin syndrome becomes a code. Obviously, there's weight gain to consider. Needless to say, follow a clean, healthy diet. Okay? Okay. Okay. So, briefly going over the same thing. Supportive measures, obviously, so immediately discontinue the med. Okay? You're going to give them a benzodiazepine, whether it's lorazepam or, I don't know, Valium. You don't have to focus on it, but you give them, just know that a benzodiazepine for the anxiety. Okay. Now, 3 main meds that we love to give. Okay. Propranolol, that's the Inderal. Know that. Okay. And then Sansert blocks serotonin, and Periactin. Okay. It's an antihistamine. Okay. Those are the anti-serotogenic agents that we give against serotonin. Okay. Now, since the main symptoms are also muscle rigidity, fever, like I would bold fever, dantrolene, bold that one, is also given for serotonin syndrome. It's not going to pop up on my exam. Little Birdie said it's not popping up on the proctor too, but just know that if they do have serotonin syndrome, you call the doctor, you stop the med, chances are he's going to give propranolol, Inderal, or dantrolene, okay, along with the other meds. But those are the most common choices, okay? Are you guys with me? This made sense? It's important stuff to know, yeah? Now, with SSRIs, discontinuation syndrome is very important to consider because it's something that happens. Specifically with Paxil. Paxil has a very short half-life. So, with SSRIs, right, sexual dysfunction is very common. GI upset is a very common adverse effect. So because of it, patients are like, screw it, I'm not going to take this. It's messing me up. My stomach hurts, my libido's decreased. I am not taking that stuff. The other day, my patient said, I'm not taking that shit, you take it. That's what he said. I said, okay, sure. And guess what? He had a fever later on, flu-like symptoms, pins and needles, nausea, dizziness, discontinuation syndrome. You stop the drug and you start to experience all of that. With Paxil, it's very common, again, because there's a shorter half-life. The drug doesn't stay in your body. Now with Prozac, which is also an SSRI, it's a longer half-life, 4 to 6 days, stays in your system for 16 weeks. So chances are you might not even get discontinuation syndrome. Okay? Does that make sense, guys? So with Paxil, with this specific SSRI, we're going to watch out for discontinuation syndrome. And we get dizziness, nausea, pins and needles, flu-like symptoms. Okay? Okay, SNRIs. So you guys, whenever you're studying for these meds, the med sheets should be your bestest friend forever because they're grouped together. It's easier to understand them like that. And my slides, I grouped my slides based off of the med sheets, okay? So SNRIs. Okay, so SNRI targets your norepinephrine, okay? So these are the most common meds, SNRI meds, Effexor, okay? Cymbalta, I would bold that one. Very commonly used. They're like candy on the unit. Okay? Effexor and Cymbalta will cover those two. Okay? So, SNRIs, Effexor and Cymbalta. If any SNRIs pop up on your exam, I promise you it'll be these two, and even on proctor, because a little birdie told me, increases serotonin, norepinephrine, SNRI. Okay, so obviously there is serotonin, right, in these drugs. They target that too, so you still gotta watch out for serotonin syndrome. However, these meds, you gotta watch out for hypertension. So you gotta make sure you get history from your patient. Okay, you gotta make sure you get history. Hey, so many commercials about it. That's true. Cymbalta. So if your patient has hypertension, please be very cautious. Monitor that blood pressure like a hawk. Okay? If your patient doesn't have hypertension, I promise you he will get hypertension. This is how horrible these drugs are. Okay? Now the side effects, nausea, vomiting, weight gain, sexual dysfunction. If my patient is on these drugs and they experience that, it's expected. So I don't really care. I don't want to say I don't care, but I'm just saying on your exam, don't care. It's expected. Okay, what I do care is about hypertension and possible serotonin syndrome because they're adverse. Does that make sense, you guys? Right? Just a way to remember. TCAs, tricyclic antidepressants, a different class of med. Also, antidepressants increases serotonin and norepinephrine. Okay, these are the lovely drugs in this category. So, according to theory, they're all very common, but I promise you, the one that I've administered like candy on the unit is the first one. Elavil, amitriptyline. That is so freaking popular. But guys, know all of them. Elavil, anafranil, tofranil, luteomil, the ILs, TCAs. Okay. Doxepin is very common too. Doxepin is extremely common. So these are TCAs. Now, with TCAs, your side effects are anticholinergic. Do you guys remember hot and dry? Can't pee, can't see, can't spit, can't shit. TCAs have the same freaking side effects. Okay? So if my patient is on amitriptyline, I'm expecting him to be a little bit drowsy, sedated. I'm expecting his blood pressure to drop every time he stands. I'm sometimes expecting him to kind of have dysrhythmias a little bit. I'm going to watch out for that. Sweating, possible seizures. So, urinary retention, constipation, dry mouth, blurry vision. Same interventions as before. So they're constipated, increase their darn fiber, increase fluids, okay? Hey, sit up, sit still a little bit, then I'll take your vital signs. Sugarless gum and candy for dry mouth, okay? So the constipation with this drug is it's just huge, okay? We had a patient on the unit who nothing would help him. He would gradually get combative, and he was on the unit for like a good 2-3 weeks. And he became combative, he would cuss up a storm, nothing would help him. Turns out, we asked him finally when his last bowel movement was. The man didn't use the restroom for like a whole month. Because he was on this drug that caused constipation. And it was never asked when he used the restroom. It would just be written in his eyes and nose. Yeah, had a bowel movement today. It's something that's not asked, but it should be. It needs to be asked because it's part of assessment, but it's not asked. It's just, just like you write your respiration 16, 17, which you shouldn't, right? So the moment we gave him a bunch of enemas, he was freaking impacted. Holy crap is the literal word for it. He had a bowel movement. And guess what? He became an angel. Okay? This is why constipation, Elavil, you will never, no, he did not die. He was no longer, he was no longer, do you know how I don't want to say horrible, because that's the worst thing I can say. He grabbed, my hair was grabbed, he was combative, he was a danger to others on the unit. He was, you guys, are you guys alert and oriented? Come on. Oh my gosh. It's because you said ninja. Do you guys automatically assume angel means... I was saying he's combative. And then after he had a bowel movement, he was no longer combative. Haha. It's because he was on a TCA. Constipation. If you're on a psych drug, well, that woke you up. How dare you guys fall asleep in my class? How dare you guys? MAOIs, a different class. Only 4. Nardil, Parnate, Marplan, MSAM. All of these are popular, okay? All of them. These drugs target dopamine, epinephrine, and serotonin. These guys have a whole lot of side effects. Contraindications, apologies. And side effects. So these are the PITs. Okay? These are called the PITs. Okay, so side effects, dizziness, orthostatic, kind of anticholinergic, kind of like that. Excuse me. Hypertensive crisis is what I'm going to watch out for, and this is why. Okay, now, so these are called the PITs, potentially increased thiamine serum in your body. So remember I said a bunch of contraindications? So MAOIs interact with many meds, over-the-counter cold meds, which result in severe hypertension, and so you're going to instruct them to avoid over-the-counter cold meds because these meds taken with over-the-counter meds increase hypertension, hypertensive crisis. You're going to tell them, hey, I don't want to take it. You're going to tell them, you don't want to take it. Don't take it, because your blood pressure will be through the roof, and then we're going to call it code. Okay? Now, that's meds. Okay? Besides cold meds, okay, you want to make sure, I apologize, moving forward. Food. Okay, besides meds, there are a bunch of foods these guys cannot have. Foods rich in tyramine. If they do eat foods rich in tyramine, they will have hypertensive crisis. So MAOI equals a bunch of med and food contraindications, which lead to MAOI, which lead to hypertensive crisis. Okay, so what kind of foods? Avocados, figs, pizza, liver, smoked meat, okay, fermented, aged cheese, beer, like they can't have good stuff. No chocolate, they can't have coffee, they can't have beer, right? It's on there. Sauerkraut, they cannot have. So no charcuterie boards. And that's what I live on. Okay? That's what I live on. All of my favorite stuff. No, they can't even. What's vegan cheese made of? Depends on what it's made of. That's very specific. What is it made of? Cashews. Let's see. They could have nuts, actually. They could have nuts. It's low in tyramine. Yeah. But it's not going to be like that on the quiz. It's not going to say vegan stuff. But they just can't have all the good stuff. These are foods rich in tyramine, okay? Can you imagine, like, not having pizza, bananas, right? No stuff, no caffeine, no sour cream, okay? Cottage cheese is okay. Okay, tomatoes are okay. Bagels with cottage cheese are okay. Things like that are okay. I have a more extensive list when you come to my tutoring. Okay? Yeah. So if they do have foods rich, if they do have a charcuterie board and they're on an MAOI, they will have a hypertensive crisis. Okay? This is why you're going to educate your student nurse and you're going to tell them, you know, we can't give the same foods to everyone on the unit because everyone is on a different med, right? And different meds have different contraindications, okay? So MAOI is no cold meds and no foods rich in tyramine, okay? Because it can lead to hypertensive crisis. So MAOIs, also paroxetine, right? That's your Paxil. Paroxetine, you cannot, no, okay? Also leads to hypertensive crisis. Okay, I promise you it's on the proctor. Like, I just know that one because little birdie told me. Does that make sense, you guys? MAOI, food and med contraindication. Think of charcuterie board. Okay, now these are your atypical. These are your NDRIs, okay? So these are all very popular and utilized commonly. Atypical antidepressants, Wellbutrin, mirtazapine, okay, trazodone, they're all utilized, not all of them. So with Wellbutrin, you might as well tattoo Wellbutrin on your forehead because we're going to talk about it every single week in class because there's so many uses for it, okay? Enhances release of norepinephrine. Be careful in people with history of seizure disorder, head trauma, and eating disorders. So, Wellbutrin. Advise client to watch for headache, seizures. This drug has a very high threshold for seizures. So, if your patient got into a car accident, has a concussion, has some form of head trauma, increased chances of seizures, and if you give them Wellbutrin, increases those chances. Advise against it. I promise you, it's on the exam. Okay, and avoid administering to clients at risk for seizures. Those who are epileptic, obviously, they don't get it. Okay, that's the main thing. We also use this for smoking cessation. Okay, and then Wellbutrin, we try not to give it to people with eating disorders. Why? Because it causes weight gain. Okay, but yes, for depression we utilize it, but watch out for seizures. Okay, head trauma, then seizures. Do not administer. Okay, trazodone. It's an antidepressant, but we also give it for sleep. Okay, commonly administered for sleep. Maybe you guys have heard of it. There's a lot of commercials about trazodone. Okay, side effect: very anticholinergic, sedation, hypotension, dry mouth. Obviously, avoid alcohol, but you give them candy for dry mouth, sugarless candy, gum for dry mouth. Okay. What I want you guys to understand is the cholinergic side effects, and it's also given for sleep. It's a double use. Okay. I talked about St. John's wort. I'm gonna bring it up again. Okay, not regulated by the FDA, and you don't take it with what? With SSRIs, because increases your chance of serotonin syndrome, and it'll be fatal. Like, you can die. You can die. Okay? Photosensitivity, skin rash, increased heart rate. The main symptoms you're going to see with St. John's wort plus an SSRI. What was it? Tachycardia. Write this down. I know it's on the slides too. Tachycardia, hyperflexia, labile VP, incoordination. Okay. And skin rash usually presents, it's like all over the chest area, the back area. Obviously, no alcohol. I could have placed Meredith's picture here, right? Office fans. Or who else can I put here from The Office? Ryan. Are there no Office fans in here? Come on, you guys. Fail. Are you guys okay? What's going on? I'm gonna have you guys educate me next week. Okay. So, we talked about signs and symptoms. We talked about meds. We also utilize other forms of therapy. Now, we don't throw meds out the window when we utilize any of these. We continue with meds. Okay, we continue with meds. But we utilize this too. We're going to talk about ECT dominantly, right? Neither can I, but it's still utilized. Sadly. I used to work with an RN, and she had ECT done. And she said, I do not remember a whole chunk of my life, but it worked. It worked. We're going to talk about it right now. It's wild, right? Wild stuff. Okay. Have you guys seen Homeland? Anybody? It's a show. No. Anyway, there's a scene there where the main character actually gets ECT, and this actress actually studied psych patients and saw an actual ECT, and she played it so well. I thought this was happening right in front of me. Yeah, like how it does on the unit. Okay, ECT, electroconvulsive therapy. Okay, remember we utilize ECT. So we started our patient on meds, on a bunch of meds, remember, not just one, two, and they aren't really working. They're just not working. We're not getting the desired effect. We're still having those signs and symptoms of depression. SI, dominantly SI, it's just not working. So ECT is something that can be offered, okay? ECT is something that can be offered. So we utilize this when meds kind of don't work. We use for patients who have depressive disorder and are unresponsive to other treatments. Now, we use this when meds don't work. However, we don't stop taking our antidepressants. The doctor does not stop them. You take them and you get ECT. So, use of electrical current to the brain to create a seizure. You're inducing a seizure, okay, under general anesthesia. So this increases all your norepinephrine, dopamine, and serotonin, okay? You don't just use this for depression. You can use it for schizo, for bipolar. Obviously, you're inducing a seizure. So if there's ICP, increasing intracranial pressure, no, you don't do it. So the actual procedure. ECT is delivered through electrodes attached to the patient's temple. So there are 3 important meds that you should know for this term when it comes to ECT, okay? So 3 meds you administer. Tattoo this on your foreheads, on your arms. Anticholinergic to decrease secretions, either atropine or Robenal. Remember, you're inducing a seizure. What happens in the seizure? They can start to aspirate. So you're giving them this to decrease that, okay? Then anesthetic agent, remember it's under local anesthesia, either methotrexate or propofol, right? We're keeping them safe. And to prevent injury, we're going to give them Enectine, succinylcholine, neuromuscular blocking agent to decrease muscle contraction and prevent injury. So a lot of the times our patients are going to be like, well, you're going to give me a seizure. Am I going to hurt myself since it's not a natural seizure? No, you're going to tell them we're going to take care of you because we're going to give you these 3 meds. Less chance of choking, aspirating, right? You're under propofol, general anesthesia, and we're going to give you a neuromuscular blocking agent. Good, right? Know this, okay? Now, make sure before you do this, you've obtained consent. You can't do it without you can't do it unless your patient consents to it, informed consent. It's the first thing you obtain, okay? Now, you got your consent form. Your patient is NPO for at least 4 hours according to ATI. I would say 4 to 6 hours. 4 hours is not enough, okay? 4 to 6 hours, okay? Anticonvulsants are the only meds discontinued prior to ECT. Everything else is taken, okay? Besides anticonvulsants. You're inducing a seizure. So why would you give the anticonvulsant, right? Because they're the meds that stop you from having a seizure. Ask the patient to avoid pee, remove jewelry, contacts, hairpins, dentures, all that stuff, because you want to be safe, right? Assess vital signs, okay? EKG, vital signs before, during, and after ECT, okay? Make sure you hyperventilate your patient. Nasal cannula does not work for this. Non-rebreather mask, just go for it, okay? Oxygenate your brain, okay? Now, afterwards, short-term memory loss and confusion is okay. It's expected. Reorient them, okay? Reorient them. Tell them, don't worry, you just went through your ECT, okay? You have a headache, which is very common maybe, or assess for it, give them Tylenol, okay? And offer them food once the gag reflex is back, okay? Now, education, you're gonna educate them. This is not an every single day type of thing. It's 3 times a week, 6 to 12 treatments. Okay, 3 times a week, 6 to 12 treatments. And your consent form consents for the duration of the treatment. You don't have to get a consent form for each time. Okay? And there you go. And this is ECT. Okay? The fact that it's still utilized is kind of gnarly, in my opinion. Oh, it's 9:13. We're okay on time. Okay. Okay. Then transcranial magnetic stimulation. Memory loss is okay. Memory loss is okay. Short-term memory loss. What if they change their mind after the first treatment? No problem. They have the right to do that. Okay. No problem. The doctor is going to explain the risks of benefits from stopping ECT. No problem. What happens is if they change their mind after the first treatment, no problem at all. They have their right. And then if they want to do it again, new consent form. Okay? Well, short-term memory loss is it's not, it comes back. Short-term memory loss is fine. A little confused. But if you're talking about losing a chunk of that memory, if it's effective, if ECT is effective, you could lose a chunk of your memory. 99% of the time, what they don't remember is are the memories that actually cause them all that trauma. Does that make sense? 90% of the time when I've spoken to them, they said, I'm fine. I'm fine that I can't remember. I feel good. I feel so freaking good. I'm okay. Yeah. If there's long-term memory loss, it's because it's worked. How is that possible, right? Well, increases norepinephrine, serotonin. It like recharges your brain, right? We don't know a lot about the brain. The ECT, it like reshocks your brain, basically. Not really, no. No. Because ECT doesn't always work, remember? It doesn't always work. So there are no side effects. Think of it this way. Psych patients, look at the drugs we've discussed. All these drugs have so many side effects, yet we administer them to our patients and nothing happens. Can you believe that? They just go to baseline. These meds would probably kill both you and I. So ECT, meds didn't help. Now we've conducted and induced a seizure, and maybe that might not work. So it doesn't always work, but there are no side effects that I've witnessed within the past 8-9 years. Yeah. No, it's used for schizophrenia. It can be used for manic mania and bipolar disorder. It can be utilized in a lot of stuff. Yeah. Interesting stuff, right, guys? Excuse me. Okay, let's go to TMS. So non-invasive, okay? This is where a coil is held against your forehead. It's like a buzzing sound. Kind of activates the nerve cells in the brain, okay? You just get tingling sensation. Your jaw muscles can be kind of contracted a little bit. Treatment sessions last 30 to 60 minutes. Don't require anesthesia. Milder forms of depression, we go for this one. Doesn't always work. Remember, we're not stopping meds. Remember that? Excuse me. Whoops, did I skip something? Vagus nerve stimulation. Okay. I've seen this maybe one time within the past 8-9 years. So device is surgically implanted under the skin. You have like an implant right here, kind of like pacemaker, but not really. So device surgically implanted under the skin on the left side of chest that delivers an electrical impulse every 5 minutes, okay? Used for epilepsy more than it is used for depression, okay? So you can actually deactivate this device if you place a magnet over it, okay? Obviously, don't discontinue meds, ever, okay? Hoarseness, coughing, tingling over the implanted device, okay? So it's used for depression if meds don't work, although you don't stop meds, but with epilepsy more, okay? Vagus nerve stimulation. So we've done everything, meds, ECT, vagus nerve stimulation. We don't just stop at meds. We gotta build assertiveness, cognitive assertiveness. So CBT, cognitive behavioral therapy, like how many times have you heard this, right? When we discharge them, this is what the therapist is going to work on. Assist the client to identify, change negative behaviors. Let's find that thought that makes us feel that certain way that leads us to depressive state, and let's alter it. Okay, let's build assertiveness. Okay, and then IPT, interpersonal therapy, one-on-one therapy, right? That's all this is. Due to time constraint, I'm not going to go over this. It's just a question that's not. Time is it? I want to give you guys a break. We're good on time. Once we come back from the break, we'll just go through both of the remaining chapters.